Hi, good afternoon everyone. So welcome to Surgery Dada. So let us start with this one more session of the visual fest. So let us, without wasting time, let us start with that. So yesterday we had completed a lot of topics, and again I hope the audio video is clear to everyone. Just a minute. Yeah, it's all good to go. Yeah. So I think this was the last thing that we did. We did the management of the achalasia cardia. So today we'll start from this. So we have to rush with lot of images, and just let me add a new page. Okay. So what are you seeing in this image? This is what is very important. So you can see a neck swelling. Point number one, you can see a neck swelling, and this neck swelling is in the, you can say, central part of the neck. So swelling in the middle of the neck. What could be the differential diagnosis? It could be a thyroid, you can say thyroid nodule or swelling arising from the thyroid, or it could be a thyroglossal duct cyst, something like that. Merely by seeing this image you cannot decide, but if you see this image, can you see a cystic structure has been excised along with the central part of the hyoid bone? So this surgery that is shown is nothing but suggestive of en bloc cystectomy with the central hyoid, and this is the cyst trunk procedure which is being shown here. So this is the cyst trunk surgery, and thus we come to a conclusion that the swelling that you are seeing in the image is thyroglossal duct cyst. So what are the true things that, or what the question says all except are true. So let us read it. They are lined by columnar epithelium, absolutely true. En bloc cystectomy is done, absolutely true. Infrahyoid location is the most common site, absolutely true, because they are mostly resting around the hyoid. So infrahyoid, juxtahyoid and suprahyoid, they are the three locations that we have. Students, it may be associated with MTC, it can never be associated with MTC. Why? Because the origin is totally different. So MTC is arising from the ultimobrachial body, so it is having a neuroectodermal origin, which is not possible in this case. Without wasting time, I will discuss 5 important points on this, and why this is very interesting. Let us try to understand. When we talk about the thyroid swelling, a swelling of thyroid versus thyroglossal duct, what is the first thing? So you get a midline swelling. Yes, you get a midline swelling, but midline swelling with movement, here you will have the movement with deglutition also, and with the protrusion of the tongue. So with the protrusion of tongue, who will move? Answer is the thyroglossal duct cyst will move. Why? Because it is connected to the base of the tongue. Try to understand. Now the next very important thing is, sir, what is the epithelium that is associated, and what is thyroglossal duct cyst all about? It is nothing but the cystic enlargement. It is nothing but cystic enlargement of persistent thyroglossal duct, and this is what is very important. So why that cystic enlargement happens, this is very important. Try to understand, at the time of the birth, the thyroglossal duct is there, but cyst is not present. Why? The cyst is also not present. The cyst is present, but it is not, you can say, palpable, or you can say clinically detectable. Why at the time of birth it is not there? Let me tell you, the story lies in the special epithelium, and it is lined by ciliated columnar epithelium. Do you know, because of the ciliated columnar epithelium, the cyst has an excess and progressive and constant secretion of the mucin, and therefore what happens over the time, by the second or the third decade, this becomes, yes, swollen, palpable and clinically appreciable. So remember, at the time of the second and the third decade, do you know, this becomes swollen enough to be detected clinically, and that is the reason over the time, now if you don't treat this patient, the rupture has to be happening. So either the rupture will be spontaneous, or the rupture is iatrogenic. So either spontaneous or iatrogenic. The moment you rupture it, you land up with what, students? A fistula. And this is what is very important, that cyst is congenital, but fistula is always acquired. This is what is important. Now, when we talk about the risk of malignancy, less than 1% risk of what, students? Malignancy. However, what kind of cancer will arise. Now for this you need to understand that during the development of thyroid, development of thyroid occurs from the, yes, two parts. The medial part of the thyroid develops at the level of the base of the tongue. Do you know, at the level of the base of the tongue you have foramen of cecum, and then we have the lateral part of the thyroid which is developing from the fourth pharyngeal pouch. So do you know the lateral part in the future will give rise to parafollicular cells, and this is what is very, very, very important, and it is the medial part which is contributing to majority of the gland. So it has to come down, and therefore there is a bilobed pedunculated, you can say, extension of the medial part, and this is what is very, very, very important. This pedunculated part gets a name of thyroglossal duct, and the lobes, they are going to fuse and form the, you can say, majority of the thyroid. Do you know, at the fifth week of life, the fusion happens, and the moment the fusion happens, the regression of the thyroglossal duct starts, and this is why it has to start its regression by fifth, and the regression should be completed by 8th week of life. If it fails to complete the regression by 8th week of life, it will be known as a persistent thyroglossal duct, and it will present in the newborn also, and over the time it will start a cystic enlargement. Now I want to tell you that there is no relation of the thyroglossal duct with the what? Lateral part of the thyroid, and lateral part of the thyroid which is developing from the fourth pharyngeal pouch, from the ultimobrachial cells, they are neuroectodermal, and that is why they will contribute to MTC. So point number one, first of all, MTC will not occur. If the cancer can occur, it is all the cancers which can arise from the follicular cell. So papillary, follicular, anaplastic, every cancer can occur, but what can never occur? Answer is the MTC. So in fact, the risk of malignancy is less than 1%, but still if someone asks what is the most common, the answer would be what, students? Papillary, papillary, papillary. So without wasting time, let us go and do the next question. So what is the answer here? It cannot be associated with MTC. Next is, I've already discussed this question. Now, all of the following are positive with respect to this image. Now try to understand. 38-year-old male presents with 38-year-old patient presents with erosion of the nipple areola complex and encrustation. The classical image shown in this case, it is suggestive of what, students? Paget's disease. So this is suggestive of Paget's disease, and then they are asking the following questions. What? Answer the following with respect to image. So all except are true. All except are true. Let us try to find it out. So Paget's disease, are they associated with the Paget cells? This is absolutely true. They are mostly associated with DCIS. Yes. Simple mastectomy may be preferred management. So simple mastectomy or BCS. Remember, they don't stain positive for Argenta fendis. This is what is the exclusiveness. So many a times you get confused whether this encrustation is due to Paget's or whether it is due to certain other things. But Argenta fendis, they are not positive. So they are PAS positive. They are, you can say, Elchian blue-black positive. There are certain tumor markers which are positive for them. So let us understand Paget's in next 2-3 minutes. This is what is very, 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 very important for us to understand the concept of Paget's. When we talk about the Paget's, what is the important thing about the Paget's disease? Do you know? Let me tell you the theory of transductal migration, and this is what is very, very, very important. So imagine there is a cancer in the, you can say, in the duct. The ductal cancer cells shall migrate to the, you can say, level of skin. And how do they reach to the skin? Answer is with the migration, via duct, and they reach the nipple areola complex. And slowly they damage the nipple areola complex, and then they spread on the cells, they spread on the surface. Do you know, as they damage the cells of the, you can say, nipple, as they damage the nipple areola complex, what is presented as encrustation is nothing but the damaged epithelium with the superficial spread of the cell. Remember, superficial spread of the cell. Paget cells don't invade. So remember, there is superficial spread of the tumor cells, This is just like an alga floating on the surface of a pond. This is what is very, very, very important. So spread of the tumor cells along the skin. Remember, there is no dermal invasion, and this is what is very, very, very important, because if it is dermal invasion, then that is not a Paget's, then that will be something different. So that will be a T4B. It's a skin invasion now. Most common tumor associated with this, answer is it is associated with DCIS more frequently than what, students? Invasive ductal cancers. However, it is ductal cancer, ductal origin tumors which cause Paget's disease. Now, do you know, we often get to see what is the clinical presentation? I've already told you: eczema, encrustation. So eczema or itching, encrustation with nipple discharge. This is what is the classical presentation. Now, how can you differentiate eczema versus a true eczema versus Paget's disease? Because the presentation is basically the same: encrustation, excoriation of the skin. The answer is, first of all, the location. The location of Paget's disease is always the neck and the area around the neck. Whereas eczema might involve neck or might not involve neck. So suppose if it is not involving the neck, it could be anything but not a Paget's. But the problem arises with an eczema involving the nipple areolar complex also. So how to sort it out? Try to understand the response with steroids. This is what is very, very, very important. So if you give steroid, eczema will be responding, but there will be no response to the Paget's, and that is what is very important. Which condition tends to be bilateral? This may be bilateral, this is never bilateral. Do you know what is on histology? What do you get to see in case of Paget's? And this is what is important. They are PAS positive. They contain Paget cells. So Paget cells are special cells which are PAS positive, or students Elchian blue or black positive. Now there are 2 or 3 more markers which I am going to mention for you. What they are, students? They are positive for mammoglobulin or mammoglobin. So mammoglobin positive, this is one more thing. So mammoglobin positive. They are also positive for CA19-9. Now this is what is a marker which is usually elevated in hepatobiliary and pancreatic tumors. So CA19-9 is also positive. Some of them are positive for CA27 to CA15-3. So these are the certain markers which may be elevated. They are also positive for mucicarmine. So these are certain markers which are positive for them. Now what is the management? We already know that it is the breast conservation surgery or simple mastectomy. So this is absolutely wrong. Let us go to the next question. Students, what is the incision that has been made over the breast? Now if you see, this incision is not a short incision, it's a big incision. Yes, it's a big incision covering entire medial to lateral margins of the breast. So this would never be for benign surgeries. So remember, Webster's and the Webster's and Oring, there is nothing known as Oringer surgery. So Webster's, it couldn't be there. Now what is Stewart, what is OR? Let us understand. So transverse elliptical is Stewart and oblique elliptical is OR, and this is a transverse elliptical incision. So the transverse elliptical incision of the breast, this is what is known as the Stewart incision. Let us give 2 minutes and understand the kinetics behind the breast incision also. So when we talk about the breast incisions, what are the important things that we need to understand? So breast incisions, there are 2-3 wonderful things that we need to understand. Whenever we talk about the breast incisions, we need to understand the purpose of the breast incision. So there are 2 things. So what is the purpose of the breast incision? If the purpose of the breast incision is cosmesis, so when we talk about cosmesis, that is for the what condition? For the benign cases. For the benign cases. This is what is very, 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 very important. Very important. Benign cases. Next is when we talk about the other one, that is the malignant. So the another one is exposure and clearance. So for malignant cases, we require exposure plus clearance. For them, that is for the malignancy. So benign cases and malignant cases. For cosmesis, they have to be hidden along the natural contours. So if this is the breast, this is the dark nipple areolar complex, you may make an incision along the nipple areolar complex in a circumareolar fashion, and that is why this incision is known as circumareolar incision. Otherwise, you can lift the breast up and make an incision on the under surface, and this is what is known as inframammary incision. So what are the two incisions that we talk about here? One is the circumareolar incision. Circumareolar incision. When we talk about circumareolar incision, this is also known as Webster's incision. What is this incision? This is the inframammary incision, and when we talk about the inframammary incision, what is this incision known as? That is known as Gallard-Thomas incision. So there are two classical incisions that we make for the benign cases. Now when we talk about the malignancy, we have to make an incision which should cover the entire surface of the breast, and that is why we go for elliptical incisions for them. So when we talk about elliptical, for the lower quadrant tumors, for the mid, you can say, location of the tumors, the elliptical transverse is going to work. So this is elliptical transverse. For the tumors along the upper quadrant, we require the elliptical oblique incision. So let us try to see them. Remember, the same incisions will be extended to go to the axilla also. So this is elliptical transverse. And what is elliptical oblique for the upper quadrant tumor? So if the tumor is in the upper quadrant, yes, the incision would be something like this, and this is what is known as OR. So OR incision is oblique elliptical, and Stewart incision is horizontal, or you can say transverse elliptical. So let us see this image, and according to this, now this is what, students? A Stewart incision is the answer for this question. Let us understand, it's a straightforward question. Identify the maneuver that is shown. So what is this maneuver for? This maneuver is for the, you can say, for securing airway. So when we talk about securing airway, you need to understand, whenever you bring a patient to the ER room post RTA, so you have to secure the airway. And airway being anterior, you have to straighten it up. So how can you straighten it up? This maneuver, this is what is known as chin lift. This is what is important. This maneuver of pushing the head back, this is what is known as head tilt. Why head tilt? So that you can realign and straighten up. Sometimes there may be displacement of temporomandibular joint, so you require a jaw thrust. So if you put a jaw thrust, so this is how the jaw thrust is given. So the third maneuver is jaw thrust. So what is shown here, students? Remember, chin lift is the answer here. Now if I ask you what is not done during the airway survey, students, answer is the head lifting is not done. Head tilting is done, but you are not allowed to head lift, because many a time there may be fracture of the atlas, and this might be actually at the level of C1, C2. This might be actually detrimental for the patient's respiratory. This may cause a patient's respiratory arrest because of the damage to the cervical level of spine. So we don't, you can say, elevate the head from the bed. So we tilt, yes, we may make some maneuvers, that is what is done. So this is about how we secure the airway. Let us move forward and let us see this image. Now this image you might not have been able to see in the clinical practice because we don't practice it anymore. But yes, this is very interesting. Let us read the scenario. A patient presents to ER following RTA. The patient has been instilled with 1 liter of warm saline into the peritoneum, and this is the procedure. So first of all, what is the procedure you are doing? Students, I am, you can say, instilling warm saline and aspirating out. So one thing is clear, that I am doing a what? I am doing a lavage. So this is a lavage of what cavity, students? Peritoneal cavity. Remember, the aim behind this lavage is diagnosis, and therefore this kind of lavage is known as diagnostic peritoneal lavage. So the image shown in this box is showing you DPL. This is what is very important. So this is a DPL, the procedure. Now what is the indication? Why do you need a lavage? Remember, the DPL is indicated. Let us quickly understand 4-5 important points about the DPL also. So DPL, diagnostic peritoneal lavage. Whenever we talk about diagnostic peritoneal lavage, the first indication or the only indication nowadays is unstable blunt trauma patient. Why? Because unstable penetrating injury, you know that you have to take a call for surgery. For unstable blunt trauma, your ball is rolling in between the two courts. Should I operate on this patient or should I continue with the conservative management? And that is the time that you take a call for what? Yes, DPL. And this is what is very, 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 very important. Remember, what is absolute contraindication for DPL? This is important. The absolute contraindication for DPL is fracture pelvis. This is one thing. The another patient with pregnancy. So patients who are pregnant. And the third is where you have a previous laparotomy. So previous laparotomy, remember, fracture pelvis and pregnancy. What are you doing in this? So this is a blind technique. First of all, this is not a radio guided technique. It's a blind technique where you put a needle. So where you put a needle inside the peritoneal cavity. Once you put a needle, then you try to aspirate out something. So once you have done this, then you attempt aspiration. This is what is very, 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 very important. On aspiration, if you get the blood, so this is considered to be DPL positive, and thus you take the patient for what? Surgery. If there is no blood, then what to do? In that case, you will have to push at least 1 liter warm saline. So this is what is very, very, very important. 1 liter saline is pushed, and once you push 1 liter, at least 300 ml, so 30% is aspirated out. So at least 30% is aspirated, and when you aspirate it, it is examined biochemically. This is what is very, very, very important. So when you examine this content, then you decide whether it is DPL positive or no. So when we are doing it for a patient with blunt trauma, we can expect two types of injuries. It could be a hollow viscous injury or it could be a solid organ injury. So when we talk about DPL positive, what do you mean by DPL positive? So DPL positive with respect to the hollow viscous injury, this is hollow viscous injury, and DPL positive with respect to what, students? Solid organ injury. So we have solid organ injury, we have hollow viscous injury, and this is what is making it very, very, very important. What is the DPL for solid organ injury? When we talk about solid organ, they will bleed. So more than 10 ml blood on aspiration, or more than 1 lakh RBC per ml, or students, or more than 500 WBC per ml, or remember more than 75 international units per ml is if it is the amylase lipase level. So amylase level more than this is considered to be what? Significant. This is what is very, 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 very important. When you talk about a hollow viscous injury, you will have a bowel perforation. So if there is bowel perforation, either you will have food, or you will have the bile, or you will have the bacteria, or you will have the stool on, you can say, aspiration. So these are the cardinal things that we have. So this is how we decide whether it's a DPL positive or no. Today DPL has been replaced by FAST, so we don't do DPL. This is what is very, very, very important. The next is, a patient has underwent a duodenal surgery for bleeding peptic ulcer disease. So bleeding peptic ulcer, and the most common site is D1. Following is the repair done for this patient. So if you see what has been done, you have done duodenotomy. So you have already done duodenotomy, and you have done the, you can say, ligation of bleeding vessel. So one thing is clear, that you have ligated the bleeding vessel. Now you want to do the closure. What is the problem with the closure? The problem with the closure is the duodenum is having a very narrow caliber. So if you open the duodenum like this, and if you attempt to close it like this, what will happen? There is a very high risk of development of what, students? A stricture. So you will go for horizontal opening or transverse opening and a perpendicular closure. This is what is very, very, very important. So longitudinal opening, and followed by what type of closure? Perpendicular closure. What is the advantage of doing this longitudinal opening and perpendicular closure? The answer is very simple, that it gives you an ample of space, and this is what is important. So just see in this image, you will take two stay sutures along them and you will pull these ends apart. So you will pull these ends apart, just see. And then what you have done, just see, you have pulled these ends apart and now you are vertically closing them, So this is what is known as a pyloroplasty, or you can say a generalized term is stricturoplasty. And this surgery is known as Henicase Mikulicz pyloroplasty. So Henicase Mikulicz pyloroplasty. This is a way of closing the duodenum whenever we talk about the peptic ulcer disease. Do you know, I told you when I was teaching you the choledochal cyst that whenever we do a duodenal opening for the transduodenal, so suppose I am talking about any surgery at the level of the ampulla. So if I open it like this, I've yesterday told you that at the junction of 2/3 and proximal 2/3 and lower 1/3 of the C loop, we will open it. When it comes to the closure, how do you do the closure? Yes, yesterday I was explaining you that if I open the duodenum like this, how will I close? Again, I will do the very same thing. I will take some stay bites and I will stretch them. So when I stretch them, this is going to be something like this. And then what I will do, I'll take a midline closure. So when I do a midline closure, this will become something like this. So can you understand? This is going to become something like this. So I'm closing the duodenum. I'm closing it like this. And now I will take one purse string suture and I will ligate it here. I'll take one purse string suture and ligate it here. So eventually this is how the duodenum is closed. We understand and utilize one property that if you are opening the duodenum longitudinally, close it perpendicularly. This is the only way of closing the small gut, especially when we talk about the duodenum. Next is, let us identify this instrument. What is this instrument, students? If you see the image, you are taking out the graft of a skin. And remember, this looks like a mechanized, you can say, or more sophisticated Humbee's knife. So this is not an Humbee's knife. This is electronic dermatome. This is what is very, very, very important. So this is electronic dermatome. It's not a Humbee's knife. It's an electronic dermatome. And what is the utility of this instrument? Yes, it is used for harvesting of the graft. This is what is very, 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 very important. So harvesting of the graft skin. Now whenever we talk about the harvesting of the graft skin, remember 2-3 points which can be asked to you as a question. What are the important things when we do a graft harvesting? Whenever you are doing a graft harvesting, always remember the contractions can happen. So it was asked in recent exams also about the contractions of the skin graft. When we talk about the skin graft, there are two steps. So we have the donor and we do the procurement. So we do a procurement, or this is known as harvest. So we have done a procurement and harvest, and then we apply it on the what, students? Recipient bed. So this is how we do recipient. You can say recipient side, you can say you have deposited it. So there are two contractions. The contractions that can happen in life of a graft. Primary contraction is the shrinkage of the graft. The shrinkage of the graft after harvest. This is what is very, very, very important. So after harvest, but before grafting. So you have not put it. So I have taken, suppose this is a graft, I have taken it from this side. The moment I take it out, there will be some contraction because of the elastic recoil. And now I am placing it here, and again there will be some elastic recoil. So there are two contractions. One is after the harvest, before the graft, and then we have the secondary, which is the shrinkage, associated shrinkage of graft post grafting. This is what is very, very, very important. So graft with contractions are not required, but any graft with a higher secondary contraction is the most you can say useless type of graft. So remember, for all those split thickness skin graft, they have high secondary contractions and they have low primary contractions. When we talk about the full thickness skin graft, they have low secondary contractions, and that is why they are considered to be best. But still we use split thickness skin graft. The only reason is that the split thickness skin graft is in abundance You can take it out. The maximum that you can expect is the rejection. You will have again another site available. Meanwhile, this site will also get ready. So split thickness skin graft, due to its excessive availability, they are the most commonly, you can say, used graft. This is what is very important. 2 lines on the split thickness skin graft. What is the concept of split thickness skin graft? You are going to split the variable thickness of the skin, and split thickness skin graft are further of 3 subtypes. We have the thin variety. We have the thin split thickness skin graft, which is also known as Thiersch-Ollier graft, and this is what is the most commonly used. So we have Thiersch-Ollier graft. When it comes to the most commonly used overall, so this is the most commonly used overall graft. Do you know, when we talk about their thickness, it is 0.006 to 0.014 inches thick, and this is what is very important. Then we have the intermediate thick split thickness skin graft, and this is what is again very important. This is known as the Paget's graft. This is known as the Paget's graft. No, this is known as the Blair-Brown graft. Sorry, this is known as the Blair-Brown graft. This is again important. So Blair-Brown graft. Now, when we talk about the Blair-Brown, it is 0.014 to 0.018 inches. The last is a thick variety of STSG. Remember, when we talk about the thick STSG, what do we mean? Any thickness leaving behind the reticular part of the dermis. So this is known as Paget's graft. This is known as the Paget's graft. This is Paget's graft. And remember, 0.018 to 0.024 inches, at least reticular dermis should be spared. When we talk about the full thickness skin graft, it includes 2 important things: the epidermis, and along with that, the dermis. This is what is important. Remember, this is also known as Wolff cross graft. It is known as Wolff cross graft. Apart from this, you need to understand, since I have written the word measure, what is the concept of the measure or Wolff measure? When we talk about the skin has an elastic strain, and I can stretch it up to a limit only. So what if I make the meshes or the holes in the graft and reduce its elastic strain? So what do you mean by meshing of the graft? What do you mean by meshing of the graft? So there is something which is known as meshed graft. Mesh graft means meshing of graft in order so that there is increase in the surface area, point number 1. The another point that you need to understand is, majority of the time the graft rejection happens. Why? Because between the recipient bed and the, you can say, the graft, there is accumulation of what? The hematoma or the serous content. So serous exudate, the hematoma accumulates in between this, and therefore the rejection happens. So when you make the mesh, when you make the fenestrations or the gaps in the, you can say, skin, the collection underneath, first of all, the elastic strain has been reduced, you can increase the size, the collection can come out, and therefore this increases the acceptance. So meshing of the graft is done to increase the acceptance of the graft and to increase the surface area. This is what is very important for all of us. This is what is, yeah. Humbee's knife, Niharika, we use Humbee's knife. I will show you the image also. If you have said, I'll show you the image also. What is the maximum increase that can be done? The maximum increase that can be done is 1:1.5 or 1.6 times. Yes, if you have asked for this Humbee's knife, I hope I'll show you the Humbee's knife also. So Humbee's knife is a very common image that you must have seen. I'll just show and add it to you. Just give me 1 second. I'll add the Humbee's knife also. I think I must have shown you in the class also many a times, but okay. Try to see. This is, let us see this. This is the dermatome. This is what is Humbee's knife. Can you see? So this is what is a classical Humbee's knife. So this ustara looking like a barber's ustara that they use for shaving. So that is what is a Humbee's knife, yeah. And a razor, or you can say a trimmer kind of, you can say, appearance, if you see, that's an electronic dermatome. This is what is very important, very important. Let us move forward now. Let us go to the next image. Yes, because we have to cover a lot of things. Okay. So 32-year-old male patient presents to you with painful postprandial swelling in the submandibular gland region. So painful postprandial swelling in the submandibular gland region. So you can see, what are you dealing with? You are dealing with acute obstruction of the submandibular gland, and this is what is very important. So what is the most common cause in this young male? Answer is sialolithiasis. So the most probable diagnosis, answer is sialolithiasis. The patient presentation complex that we are talking about, what is that, students? This is associated with salivary colic. So what are the important things that we need to understand? What is salivary colic? The painful, you can say, increase in the symptoms of pain postprandially, it decreases. So that is why it is known as colic. Let us understand 2-3 important points on this, and let us make some beautiful concepts. So whenever we talk about sialolithiasis, let us understand all those things. It is nothing but the stones in the salivary gland. The most common site for them is the submandibular gland. There are only 3 reasons for that. First of all, this is anti-gravity drainage. The secretion is rich in the calcium, therefore it is viscous. And do you know this, you can say this submandibular gland duct, that is the Wharton's duct, is, you can say, hooked by the lingual nerve. So this hooking by the lingual nerve, all these things improve, or you can say, sorry, they increase the stasis of the flow, and if there is stasis of the flow, therefore the stones will precipitate. Very good, Niharika, very good. So when we talk about the presentation, what is the classical presentation? Students, whenever the patient will eat, will have a sight smell of the food. So the food, whenever the patient attempts to eat, there is increase in the resting salivary flow, and the saliva wants to come out, but it cannot come out. Why? Because of the stone. And therefore there is extensive distension of the submandibular gland. So therefore the patient will have pain and tenderness. So pain and tenderness plus swelling over the submandibular gland region. This is what is very important on food intake. This is why the patient is also giving you the typical complaint. Do you know these symptoms will gradually decrease? So these symptoms, symptoms of pain and tenderness and swelling will decrease 2 to 3 hours postprandial. So when we talk about the pain versus time graph, this is how the things are. So the pain intensity increases, comes to the baseline, that is why it is known as colic, salivary colic. Sometimes the pain may also be referred to the tip of the tongue. And why? Because the stone in the duct, Wharton's duct, might be irritating the lingual nerve also, and that is what is a referred pain. Let us try to understand quickly what is the management for these stones. What is the management? Whenever we talk about the clinical suspicion, you need to go for confirmation. For confirmation, the first line investigation is a simple orthopentomogram. Remember, the investigation of choice is a classical NCCT, because majority of these stones are radiolucent or radiopaque. Radiopaque. Next is what is the important thing that we need to understand? So the treatment is, it depends upon location with respect to lingual nerve. This is what is very important. Location with respect to lingual nerve. If it is located anterior versus if it is located posterior. Now this is what is very important. If it is located anterior to the nerve, the approach for these patients will be oral approach. So what are you going to do in this case? You are going to enter inside the oral cavity, you are going to open the duct and relieve the obstruction by taking out the stone. So this is known as ductal exploration with removal of the, or with the stone retrieval or stone removal. Remember, this is in the floor of the mouth, so you don't need to close the rent where you have done the ductotomy. But the posterior approach is totally different. the stones in the posterior part of the, you can say, of the gland, posterior to the lingual nerve. So whenever you have a stone posterior to the lingual nerve, you have to use a cervical approach. When we talk about the cervical approach, what is that cervical approach? Try to understand. Suppose this is the duct and the, you can say, this is the hooking of the duct by the lingual nerve, and here you have the stone. You cannot go via oral approach. Hence 2 cm below the mandible you will make incision over the submandibular gland. Ligate the duct as high as possible, because if you don't ligate the duct, there is a risk of fistula. So in this case, you will have to ligate the duct as high as possible, and then along with the stone, you will have to take out the duct and the gland and the stone. So remember, cervical approach, and what are you going to do? Ligation of duct as high as possible under the vision, and along with that plus removal of gland with the stone, removal of gland with stone. This is what is very important. Now important is one more update. Why I have kept this question update? Today we can go for a intraductal scopy and removal. So today we have ESWL also. So ESWL is preferred for less than 5 mm non-obstructed stones. So less than 5 mm stones, yes, they can be removed with this ESWL based technique. So this is what is very important. Another thing is, the stones less than 5 mm can even be retrieved by doing a Dormia basketing also. So intraductal cameras, there are 2 mm, 3 mm scopes, that the same scopes that we use for what? The ductoscopy for the breast. Same scopes can be inserted, and you can do a crushing, removal, Dormia basketing for those stones also. So yes, there have been updates. You can do ESWL also for these patients, but the stone size should be up to the 5 mm or less than 5 mm. Let us move forward and let us see. Answer the following. What are you seeing in front of you? What are you seeing in front of you in this thing? Let us understand this. We are seeing 2 syringes with a chemical, white color chemical. So this 3-way cannula with 2 syringes attached to this. So what is the principle? I am doing nothing but mixing the air with the what, students? Drug. And when I am mixing the air with the drug, my aim is what generation? Foam generation. And this is what is known as what technique, students? Tessari's technique. So this is a Tessari's technique that we have. What is the indication for them? Answer is, for the indication is for chronic do the oxidation of air with the what, students? With the drug. So 10 to 15 oxylations are sufficient, and then you can say inject this foam into the target vein, and this is what is important. Now this is very important. Many of us think that we are doing it for the varicose vein. Remember, less than 3 mm means it qualifies only for 2 category veins, for reticular veins, and for the another one is the telangiectasias or the spider veins. Otherwise it is not useful. What is the composition that we use? I have already told you, 4:1 composition is what we use, is drug and air. And when we talk about the drug, what is the drug that we use? We use sodium morhuate. So we use sodium morhuate. This is one, and the another one is tetradecyl sodium. So we have tetradecyl sodium and sodium morhuate. These are 2 important things that we need to understand. Next is, let us read this question. Identify the grade of biliary injury. So for this, I am asking with respect to the Bismuth-Strasberg, answer me according to Bismuth and Strasberg. Recently I have also taught you the Hanover classification, the other classifications also, but according to Bismuth and Strasberg, tell me about the injury. I'll enlarge this image for you so that you are able to see a lot of things. If you see, this is the ampulla, the duodenal ampulla that we have. This is the CBD that you have, this is the CBD that you have. Can you see, this is the cystic stump, this is the cystic stump, this is the cystic stump. There is a drain here, there is a drain here. What else? This is the hilum, of the patient. What else can you see here? Try to understand this. Just a minute. Okay. What else? Students, this is the left duct, this is the left lateral duct, this is the left medial duct. So left medial, left lateral. This is the right anterior duct, and if you see, this is the right posterior duct, and from the right posterior duct the contrast is coming out, and this is what is making it very, very, very special. Can you see? So this is an injury involving the right posterior duct. So right posterior duct is a segmental duct. Segmental duct injuries qualify either B or C. Now you have to see whether it's ligated or clipped, or whether it is having a bile leak. So this is a segmental duct injury with biliary injury with bile leak, and that is why it is a type C injury. Type C according to Bismuth and Strasberg. This is what is very, 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 very important. Let us try to understand everything on the image, and let us try to discuss quickly the concept of biliary injury, and let us discuss a brief approach of their management also. So whenever we talk about biliary injury, there are a lot of classifications for them. Let us understand. So biliary injury, I am not going to discuss the most common causes, lap, cholecystectomy, blah and blah. I am going to discuss what is the classification for the biliary injury. The standard classification that we have is a Bismuth-Strasberg classification. The only drawback for this classification is that it doesn't include the vascular injury. So vascular injuries are included in the Hanover's classification. When we talk about the Bismuth-Strasberg, one is for the cystic stump leak. For the cystic stump leak, this is one. Another one is or peripheral unknown duct leaks. This is what is very, very, very important. So suppose if there is a duct leak by a duct of Lashka, sometimes there is direct entry of small ducts from the right surface of the liver into the gallbladder, and when you dissect the gallbladder, you see small pinhole size lesions from where the bile is coming out. That's the duct of Lashka. Anyways, then we have type B. Type B is segmental duct injury with blockage. So what do you mean by segmental duct injury with blockage? And type C is segmental duct injury with leakage. Then we have the type D, that is defined as the lateral wall bile duct injury or biliary injury. Lateral wall bile duct injury. Let us try to understand all of them in form of one simple image. So if you see this to be the gallbladder, this to be the liver, this is the right duct, this is the left duct, this is the cystic stump. So you have put the clips. So if there is a leak from this will be known as A. If there is a damage to the lateral wall of the biliary tree, that is known as D. Suppose if you have ligated the right duct only, and divided it in between, so you have clipped and divided, so injury is there, but there is no bile leak, that is known as type B. So it is ligation with injury. Suppose if you have damaged the segmental duct, so this is a suppose injury to the hilum or injury to the right segmental duct, left segmental duct. So if there is injury with leak, then that is what is known as type C. When we talk about type D, what is type D associated with, students? Type E. Type E is associated with your strictures. When you talk about the strictures, what are the strictures that we have? Remember, the length of the stricture is not important. The distance or the you can say the gap between the stricture and the hilum is important, because lot of surgeries fail because of the very close proximity with the hilum. So if this is the location of the stricture, this is the hilum. If this gap is more than 2 cm from the hilum, then that is known as what, students? E1. If it is less than 2 centimeters from hilum, that is known as E2. If it is at the hilum, so this is what is at the hilum, this is what is known as E3. Remember, when we talk about the segmental duct strictures, but the hilum is paired, so you might have damaged the segmental duct, you can say isolated, so that is what is E4, but the hilum is paired. Now imagine if you have the segmental duct injury with the hilum also involved, then that is known as E5. So if you see 5, this V-like appearance is seen in this, and this is what is E1, E2, E3, E4, E5. When we talk about the injuries, the management, this is again very important. So that is why I am giving some time, because biliary injury and its management is frequently asked in exams. So let us understand, whenever there is a biliary injury, the next question is when has been detected. So time of detection is very important. So the time of detection could be during surgery it has been detected, or it has been detected, what students, post surgery. This is what is very important. So if it has been detected during surgery, what is the next thing that you need to understand? Do you know the duct? So is it a known duct? So if you are talking about the known duct, yes, it is a CBD, yes, it is right hepatic duct. So yes, if it is yes, then you will have to go for repair. Remember, if you don't know the duct, so it is not a known duct. In that case, what are you going to do, students? Simply suppose you have a duct looking like this. What is the next thing? You will insert a feeding tube, and you will put a contrast. The moment you put a contrast, the contrast will go to every section where the duct is getting drained, and thus you can determine where and how much the duct is draining, and thus you can ascertain what category of duct it is. So in that case, you will do IOC. What I have done, this is what is known as intra-op cholangiogram. So when we do intra-op cholangiogram, the next thing that you need to understand is what is the pattern of duct drainage. If the duct drainage is significant, so if the duct drainage is significant, what to do in this case? Remember, this is an important duct, and therefore repair. If duct drainage is insignificant, in that case you will always try to look for the duct diameter also. If it is found to be less than 3 mm, in that case you can go for ligation. If it is more than 4 mm, that means it's a significant duct, and therefore you will have to go for a repair. So these are certain important things which you have to follow. Now when we talk about the repairs of the duct, this is again very important. In that case, you will have to ask yourself, have you completely divided the duct? So transection is important. If the transection is there, yes, it's different. If it is no, then you will have to understand degree of contusion or degree of laceration. This is important. So if the degree of laceration is less than 180 degree, if the degree of laceration is more than 180 degree, students, this is something like this. Suppose if this is the laceration versus if it is a very wide laceration, like somewhere like this. So why I am asking this? Because eventually you will have to repair, but try to understand whenever you do a 180 degree less than 180 degree laceration, you do a primary repair. So primary closure over T tube. Why this is over T tube? Try to understand. Suppose you have repaired it and you did not insert a T tube. Post biliary injuries, post biliary surgeries, there is a temporary spasm of the CBD and the ampulla. Since there is ampullary spasm, the CBD pressure try to increase in the post-operative phase, and therefore the blowouts happen. And that is why it is very important to put a T-tube, so that if the pressure is increasing, the surface tension of the bile will ask the bile to take the least resistance and go out and get out through the T-tube drain, and that is why it is mandatory. I don't think anyone has those, you can say, balls of steel that he can attempt to repair a CBD, injured CBD, without putting a what? Drain. It's very. You can put a stent, that is okay. Next is, if it is more than 180 degree, yes, you will have to go for primary closure. But since this defect is too big, it will not be able to hold the T-tube. So you will have to insert the T-tube either proximal or distal to the injury. So T-tube with T-tube insertion at other, you can say, site. This is what is very important. Now, if there is laceration, this is the management. If there is complete transaction, what do you mean by complete transaction? This is one segment, this is another segment. The next thing that you need to understand is what is the gap in between them. This is what is very important. If the gap in between them is less than 1 centimeter, if the gap between them is less than 1 centimeter, in that case you will have to go for primary closure with T-tube insertion at another side. If it is more than 1 centimeter, you don't have any other option other than going for Roux-en-Y hepatico-jejunostomy. This is what is very important. So what is the concept of Roux-en-Y hepatico-jejunostomy? This is one end which is damaged now. This is the hilar end. This is the another end which is damaged, and this is the duodenum. So at the first, you can say, jejunal arcade, leaving first jejunal arcade, you will divide the jejunum and you will get this jejunum up and you will do the anastomosis. Remember to close this end, and this is what is Roux-en-Y hepatico-jejunostomy. So this is what is very important when we talk about the biliary injury. If it is detected post-op, now this is again important. So post-op detected bile injury or biliary injuries. The next thing is, do you have the drain in situ? So if you have a drain in situ, the answer could be yes, the answer could be no. If there is drain in situ, then the next thing is you will check about the output. If the output is less than 500 ml, if the output is more than 500 ml. If the output is more than 500 ml, you need to get ERCP stenting done. This is what is very important. If it is less than, then you have to go for observation. Go and make the patient NPO for certain time so that the biliary outflow decreases, and then you can wait and watch for this patient. So observation is the call for them. Students, if there is no drain, the next thing that you need to understand is peritonitis is there. Is the patient peritonitis? You must be thinking, sir, how do you get to know there is biliary injury if drain is not there? This is by the presence of what, students? Obstructive jaundice. So obstructive jaundice is a hint that gives you, obstructive jaundice is a hint that tells you that biliary injury is there. The very next thing that you will ask to yourself, is there peritonitis or no? So if there is no peritonitis, if the answer to this is no, you can attempt what? ERCP, what, students? Stenting. ERCP stenting can be done, or USG guided percutaneous drainage can be done. This is what is very simple. Now when we talk about yes, peritonitis is there, yes, peritonitis is there, you will have to go for a surgery. Acha, here you can also go for a diagnostic lab with drainage, with biliary drainage. So you can go for a diagnostic lab with a biliary drainage. Now if the peritonitis is there, in that case you will have to go for surgery. Now when you are going for a surgery, the next plan is decided by the duration of injury. This is what is very important. So if the duration of injury is less than 5 days, or you can say it's 4 to 5 days old, in that case you can go for Roux-en-Y hepatico-jejunostomy. If it is more than 5 days, more than equal to 5 days, in that case you have to go for T-tube drainage. This is what is T-tube drainage. Now what is the aim of doing a T-tube drainage? Let me tell you, T-tube drainage is aimed to convert an uncontrolled leak into a controlled fistula, and remember 6 weeks to 8 weeks later, allow the stricture to develop, and then you will do a what? Roux-en-Y hepatico-jejunostomy. In case of post-operative detected injuries where there is no leak, you will have to wait for 2 to 3 weeks to allow the stricture stump to dilate. Imagine there could be a condition when you have clipped the CBD and divided the CBD. Now what to do? And this is detected in the post-operative phase. So remember again, the logic is within 5 days you can do a hepaticojejunostomy, but that is done at the expert hand because the stump is in spasm. So we wait for at least 2 to 3 weeks or maybe 4 weeks also to allow the stump to dilate to fullness. Now you will say by that time sir, obstructive jaundice will be there. So in that case you can do a PTBD. So percutaneous transhepatic biliary drainage can be done so that you can just relieve the, you can say, obstructive jaundice, allow the stump to dilate. But the problem of PTBT is there, that PTBT is done only when the obstructive jaundice bilirubin level crosses 15 mg per dl. So this is done when the 15 mg per dl, because this is the case where the hepatic failure can start to occur. So PTBT is not the first line, it is only there for the palliation of obstructive jaundice, but we allow the stump to dilate. After that you plan a HJ for this patient. So this is how you manage these patients, and this is what is very, very, very simple. I hope this is clear to everyone. This is clear. Okay. So okay, let us connect in the evening again, and I'll continue from this session. Don't worry about the sessions, I'll complete all the images with you. I hope you're enjoying this surgery visual phase. So as much as images as possible I try to cover in the evening. If there is left, I'll again give you a slot, and again we will cover. I want you to learn everything related from an image, all the possible questions, how to identify the image, the important points associated with the image. So still, if your friends have not joined, do recommend Surgery Dada to your friends, do recommend Surgery Visual Fest, because this is going to be a game changer for all of you, because whenever you get an image, you get a lot of associated questions and a story behind that. Every image is different. So I'm here to explore and tell you what is the exact story behind every image. So thank you for all love and support that you have been giving to Surgery Dada. Till then, bye-bye. Hi, good afternoon everyone. I hope audio and video is clear to everyone. So let us continue with this surgical phase. As you know, some exams have been delayed, the NEET PG has already been delayed, and that is why I thought let me extend this this series for some time duration, because a lot of students other than the residents there have also joined, and they will also be benefited collaterally with this. So comment on the surgery performed below. What surgery has been shown here? Let us try to understand. Okay. So what is the surgery shown in this image? This is what is very, very, very important. What are the cardinal points that you need to check in this? Students, can you see this is a small gastric pouch? Let us be very, you can say, basic in understanding how to decode this image. So this is a small gastric pouch, point number one. The another thing that you have to understand is this pouch has been divided like a L. This has been divided like an L. And the next thing is you have two anastomosis. You have the gastrojejunostomy also. You are seeing a gastrojejunostomy, and here lower you are seeing a jejunostomy. So what kind of arrangement? First of all, this is a small gastric pouch with Roux and Y gastrojejunostomy. Are you seeing in this image? You are seeing nothing but a Roux and Y gastric bypass. This is what is very, very, very important. So this is a Roux and Y gastric bypass. So we have got the name Roux and Y gastric bypass. So what is it? What is the nature of this surgery? This is a surgery which is a combination. This is a combination of the restrictive, because you are reducing the pouch and then you are causing a bypass of the stomach, causing malabsorption. So this is a combination of restrictive plus malabsorptive surgery. This is what is very, 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 very important. So how do we see this? Let us understand. Let us understand the indications also. What are the classical indications? When we talk about the indications for the bariatric surgery, you need to understand the BMI plays the most important role. So BMI of the patient more than 40 kg per meter square, irrespective of the conditions, or BMI more than 35 kg per meter square with any of them, What do you mean by any of them, students? Like you may be having GERD, you may be having obstructive sleep apnea, you may be suffering from hypertension, or you may be having dyslipidemia. So dyslipidemia, hypertension, or you may be having GERD. So these are the classical, and diabetes mellitus also, These are the classical conditions. If the patient is having any of them, that is taken as an indication. Do you know that for Asians, the criteria is bit relaxed? So what is the criteria for Asians? Let us understand that also. For Asians, the BMI stands for less than 40. It is not 40 now. For them, it is less than 40. That is 37.5 kg per meter square irrespective of the condition, or more than 32.5 up to 37.5 basically. So 37.5 kg per meter square with comorbidity, So this is what is important. Let us try to have an overview of the bariatric surgery with this only. This is what is really very talk about the concept of bariatric surgery. I've already taught you the inclusion criteria. So inclusion criteria, I've discussed that it is the BMI, and BMI should be more than 40 kg per meter square or 35 to 40 kg per meter square with comorbidity. One more thing that you all need to understand, that patient should be psychiatrically stable. It's not like once you get this done, you start binging on the food. So all those things have to be avoided. Now, when you talk about the nature of bariatric surgery, the bariatric surgery is more of a metabolic surgery. Basically, you are causing a metabolic alteration and thus resulting in a lot of changes. So bariatric surgery is further divided into three broad categories. And what are the three broad categories that we have? The first is, it is restrictive, purely restrictive in nature. Then we have surgeries which are malabsorptive in nature. And then we have surgeries which are restrictive plus malabsorptive. So restriction plus malabsorption and restrictive only. When you talk about the restrictive category surgeries, what are these restrictive? We have LSG. Students, this is the most popular surgery. What is that? Wherever I will be using the word L. L stands for laparoscopy. So laparoscopic sleeve gastrectomy. So laparoscopic sleeve gastrectomy is this. Then we have LAGB. What is LAGB? Nowadays we are doing sleeve gastrectomy plus gastric banding, not an adjustable type of gastric banding. So it's a combination surgery. But what is LAGB? It is nothing but laparoscopically adjustable. So laparoscopically done adjustable gastric banding surgery. Then we have restrictive plus malabsorptive, in which the most popular is laparoscopic Roux-en-Y gastric bypass. So we have laparoscopic Roux-en-Y gastric bypass. Apart from that, we also have laparoscopic MGB. What do you mean by MGB, students? Again, it's a very simple surgery. All the bariatric surgeries are simple. The only thing that you need to understand the protocol, how we do it. So we have mini gastric bypass. We have lap mini gastric bypass. The third is, we have the malabsorptive category surgeries. So what are the malabsorptive category surgeries? First we have is laparoscopic duodenal switch. I will be discussing something about them, so don't worry. So laparoscopic duodenal switch, and the second is, we have the laparoscopic BPD. What is BPD, students? Biliopancreatic. So this is the classical surgery that we have. And they are having their own category. So we have malabsorptive and we have the malabsorptive. The new techniques, upper GI endoscopy. So upper GI endoscopy based techniques. So what are the upper GI endoscopy based procedures? These are also gaining a lot of popularity. So here we have again two categories. We have the malabsorptive and we have the restrictive. So what are these procedures? Let us have it in a list. So restrictive and we have malabsorptive. Let us try to understand them. When we talk about the restrictive upper GI endoscopy based procedures, the first we have is TOGA. What is TOGA? Transoral gastroplasty. So transoral gastroplasty, this is one thing. Then the second that we have, so we have TOGA. The another one we have is endokinch. When we talk about the endokinch, what is the concept of endokinch? This is again very simple. This is the endoscopic gastric plication done at the level of G junction. The third we have is POS. What do you mean by POS? Answer is, it is per oral obesity surgery endoluminal. This is what is very important. So per oral obesity surgery endoluminal. We also have one more version of POS. We are doing the same thing, but if it is done post sleeve gastrectomy, this is what is known as ROSE. So we have POS, now we have ROSE. What is ROSE, students? It is restorative obesity surgery endoluminal. So these are certain important things that we need to understand. Then we have IGBs. What are IGB, students? These are nothing but intragastric balloons. So we have intragastric balloons or IGB. Let us try to understand what is the role of IGB, what is the role of ROSE, POS, each and everything. And then we have, when you talk about the malabsorptive, we have certain barrier devices. Now, when you talk about barrier devices, what do you have in this? We have something which is known as Valentix. Valen TX, or we have endo barrier. So we have endo barrier or we have Valen TX. So what are these are nothing but the names. Let us understand them. Let us understand the concept of endo barrier or Valen TX, rose pose. What is happening? First of all, in bariatric surgery, we have an auto suturing device. So whenever we talk about the endoscopic, you can say bariatric surgery, we have a classical device which can be mounted on the endoscope or telescope, and these device, they have a stapler, and they have a, you can say, spiral holder. So what will the spiral holder do? It will bring the lumen, it will bring the wall, and this will deploy T-shaped fasteners or H-shaped fasteners, basically the same thing that we were doing in esophagus. So what we are doing, basically we are suturing the anterior wall with the posterior wall, and this is what is known as EGP. What is EGP, students? This is known as endoscopic gastric plication. So endoscopic gastric plication is nothing but you are fusing the wall of the stomach. So if you do it, so endokinch, when we talk about endokinch, this is along the GE junction and cardia. When you talk about the TOGA, transoral gastroplasty surgery, this is along the lesser curvature. When you talk about the pose, this is along the greater curvature, or you can say especially around the fundus. And when you talk about the rose, this is nothing but pose performed for the sleeve gastrectomy weight gain patients. So do you know what is the big problem with any bariatric surgery, which the patient also have to realize? Initially, suppose you have gone for a sleeve gastrectomy and this is the stomach. Do you know, maybe 2 to 5 years later, the stomach will always get hypertrophied, and then this sleeve will become what? Dilated. When the sleeve gets dilated, the weight gain is again going to happen. In that case, are you going to do a revision? No. We will go for an endoscopic gastric plication of the extra stomach that has been added, and this is what is the concept of rose. So we have rose and pose. When we talk about the endo barriers, what is the concept of endo barriers? So this is the stomach and this is the duodenum. So you need to understand, if we inhibit the reaction between the duodenal and the pancreatic juices and the food, the malabsorption will happen. So these are the special devices which have a nitinol crown. So this is the nitinol crown and an impermeable sheath. So what is this impermeable sheath going to do? It is going to collect all the food. So the food will enter inside the duodenum, pass the entire duodenum and enter into the jejunum. But the bile and the pancreatic juice are yet to meet with this. Why? Because they cannot enter into this. And thus it is wasting the entire duodenum and 10 to 15 centimeters of the, you can say, of the jejunum also. So this is what is known as endo barrier. We also have a Valen TX, which is gastrojejunal bypass. Directly it is going to bypass